Good evening. Over next 25 to 30 minutes, I shall be discussing about organophosphate. Sorry being late, coming directly from Rohtak and then I have to travel to Lucknow. I'm certain since morning it's a long day and over next 20-25 minutes because we need to know about OP and you will be looking at it what pulmonary critical care guy has to do with it. Well, I'm a hardcore internist, then have gone into intensive care and pulmonary medicine. OP poisoning is extremely important because this is one of the most common, or you can say commonest treatable cause of poisoning, and that is where the intensivists are commonly involved. So, understanding, most of you know about it, it is commonly taught in the undergraduation starting from pharmacology. Then definitely internal medicine, they do talk about it when they talk about poisonings. And later when you do your post-graduations, whether in internal medicine or whether you do it in, not in anesthesia as such, but if you do critical care, because that's the cases which you need to handle and do it. So let's look at it and understand it from a case scenario which makes you a little bit more familiar with the situation. It's a 48-year-old housewife, no comorbidities. Sorry, but I just recovered from my influenza, so maybe a little bit of a coughing, so please bear with me. Was brought to emergency with profuse sweating, excessive salivation, diarrhea, breathlessness for 2 hours after consuming some poisonous substance. This is the usual story which we tend to see in the A&E emergency medicine. And when they evaluated, they found patient was drowsy, had a bradycardia, and not only she had a bradycardia, but along with it, she was hypotensive, she was markedly tachypneic and hypoxemic. On the room air, jugular venous pulse, oil pressure was not raised, chest bilateral crepitations were there, and she had normal cardiac and pupils were, which was important pinpoint, but they were not reacting to the light. It is very important to differentiate if you have a pinpoint pupils. In opiates, they will react to light. And obviously you will not have so much of an excessive secretion, you can have a respiratory depression. So if you are finding that every single pore of the body is leaking, there is a bradycardia, and along with it you are having an evidence of respiratory failure and a pinpoint pupil, this points towards what you call classical as cholinergic syndrome. In opioids you will have a respiratory depression, you will have a sedation, and you will have a meiotic pupils, and there will be more dryness than secretions, isn't it? Because constipation usually is the side effect and withdrawal occurs, then the diarrhea takes place. Question is, how should you approach this case? Poisoning, the basic principle is that we should always look at it and try to identify the number of signs, symptoms and see where they put into, where you can put them. This is called as syndromic approach. So here, as I said, there is every single pore is leaking, there is a bradycardia, there is a pupil which are small ones and not reacting, so it fits with classically cholinergic syndrome. So whenever anything which leads to cholinergic toxicity you are going to see. The opposite of it is an anticholinergic syndromes which happen or used to see when very excessive amount of atropine used to be used later on. Patients will have a fever, dry flushed skin, they will be agitated, hallucinating, and there will be marked tachycardia and dryness of secretions including retention, and everything will disappear. That is so-called Datura-like syndrome. So that used to be anticholinergic one. Whereas symptomatic syndromes, whenever you will see, you will have a tachycardia, you will have an hypertension. And along with it, you may sometime because of this can have a cardiomyopathy because of marked acceleration of catecholamines. Sweating will be marked there and patients can have hyperglycemia. Thank you. On the other hand, when along with this syndrome you find myoclonus, think in terms of serotonin syndromes. These are a few examples I'm trying to give it up. So in this case, obviously we have identified that this patient has a cholinergic syndrome, point number one. But more important is that this person is hypotensive. This person is having a respiratory failure, hypoxemic. And obviously when these two things are there, that means there is an imminent danger of cardiorespiratory complication. So this patient has developed respiratory failure, and whether it is type 1 or type 2, that we will decide by blood gases. So when you identify two things have been there, this patient has a cardiorespiratory failure, one. And secondly, you have got probably related etiology is cholinergic syndrome. And then you start looking at what is the likely compound which caused cholinergic syndrome. That's how we go systematically within and you can have a huge smell, large smell coming up at different places when patients have taken these cholinergic substances. So our patient's relative showed us this. So what it is turning out to be monocrotophos. So it's always good. Most of the time people will get it on their smartphones or will get this. So we know that this patient has taken 30% monocrotophos. Amount still we don't know, but when it is for the self-harm, amounts are extremely large. And that is why you see duration of illness or patients on ventilators is much higher than what you have read in the Western literature. So on an average, these people will be requiring 5 to 7 days minimum of ventilation and maybe long if they get a complication on it. Is it clear? So let's move further now. Obviously, when you look at it cholinergic straight and we realize it that this is nothing else but it's an organophosphate. Whenever you talk in terms of cholinergic syndrome, you think in terms of organophosphates, you also think in terms of carbamates. Carbamate classical trade name example is a Begom. It is important to differentiate between these two things because PAM is not at all or ever used in carbamate toxicity. And prognosis relatively is better than the organophosphates. All these are class 3 insecticide, banned in the Western world, made with the phosphorylation of phosphoric acid and alcohol, and then they kept on adding the compounds, and you saw the catastrophe caused by this during World War II. In fact, these were the gases which came, sarin, sebin, which all came up. And later on we saw it in your Iraq war and then Syrian wars. So they are weapons of bioterrorism. Chemical weapons, not bioterrorism is a wrong word. They are the chemical terrorism, if people want. The same thing one has seen it in Japan. And occasionally we see that if you must have read the news, suddenly people become sick after eating laddus or after puris, etc. Especially Indian pancakes and puri in particular. It had happened in Bihar. So important for us as a clinicians, as emergency physicians, as intensivists, as internists to identify the situation. So as I said, the two compounds, that's what we are talking about. Toxicity of phosphates is higher, longer and more common. CNS toxicity is very high because it crosses the blood-brain barrier. And it is very important when you are dealing, you should preferably take a substance which have peripheral actions, a substance which have central action. And usual standard antidote, all of you know, is atropine. Sometimes in toxicity, you shift to other ones, but CNS effects of other drugs are not there. So atropine is a drug of choice. That's what we have talked about it. We are seeing a large chunk of it in our hospital. We saw it. You will see some data here. OP poisoning, we are looking at it, approximately 50% accounted by these compounds, and it's very secular as far as the age is concerned. Once people have teenage plus, you see it still continues to be, though of late aluminum phosphide incidence has relatively gone down because of the changes in packing, etc. And also we are seeing now basically herbicides and different type of herbicides coming up. For that, it's not a talk, but you need to identify them. Like we can have 2,3,4-D, or you can have a imidacloprid, or we can also seeing a lot of cases of paraquat, and paraquat is actually pain in the neck. I don't know what to do about it because it leads to later respiratory toxicity, and patients die of acute fibrotic lungs in these cases. Now, this was an observational study which we had done it in the month of in the year 2009. Over a year, it has got published now that probably this is a common pattern. Why I put it here is because it is the common pattern of poisoning which we see in Indian context, especially because we see still a lot of rural and semi-urban areas. If you come to, let's say, to Gurgaon or to the South Delhi, we are commonly seeing the rave drugs or drug side effects or pharmacological pharmaceutical, which have been prescribed, prescription drugs, and also with a lot of alcohol. Where when you go to the cities, when you go to the rural areas, semi-urban areas, a combination is there. And this is important. And you will think again, suicide, we are seeing it between male and females, but we again looked at our data at Rohtak. We are admitting around about 1800 plus cases every year in our institution of poisoning. That data is robust because what we are doing is all cases are medical legal. So we know it as per the requirements. And again, two common continues to be OP and aluminum phosphate, then followed by herbicides. We are not seeing as much of a drug toxicity which we see in your Gurugram, and for this the cases keep coming up. That shows the pattern, and wherever you practice, you need to know the pattern, which is how the things are there. And this is another issue. We have done an observation study in our intensive care units. We have hospitalized over a period of 15 months, 134, which is a big number. And when we looked at our data, even now, COVID, probably we had a relatively lesser incidences, but again, practically 1 or 2 beds in my intensive care unit. Besides, our anesthesia increased now to nearly 50 beds, 32 plus 22 trauma, with 1 or 2 cases of OP. So any time of the hospital, 2 to 4 patients are hospitalized and are on ventilators and intensive care units. Mechanism of toxicity is straightforward. All it has been taught. You can have normally you will see that there is a ACH signaling which will take place in the synapses, and ACH will be released for all activities wherever it is. Again, you should know it is a presynaptic, basically preganglionic, and then it will come up into the synapses. Sympathetics have a shorter presynaptic, long postsynaptic, which comes up in the form of nerves. Cholinergics will be long presynaptic and short postsynaptic. That is what a normal theory is. But there in presynaptic, ACH will be released. In cholinergic, at both presynaptic, preganglionic and synapse, you will see excess of, you will see secretions of acetylcholine esterases. And then obviously you will see that it is the acetylcholine esterases which squenches it and stop the signaling process, clears up, reform it, and the vesicles, it goes back, and the instruments or the hair, the ACH is retrieve back. Whereas what these organophosphorus compounds do is they block the ACH esterase activity. So reactivation of enzymes is not takes place. So it acts on the enzyme and leads to a process what is called as aging. That means if you do it within the time period when the aging has not occurred, you may again recover the enzyme. But if it goes beyond that thing, then even best of your efforts, it will not be. And the drug theoretically, which is supposed to act as a pralidoxin. But nevertheless, now we realize there are the differences within there is a class effect and there are individual effects. So you can have a methylated or you can have an ethylated ones. So methylated ones are the ones which are far difficult and far shorter life. Therefore, if you don't act within a time period, whatever the PAM you use is useless. And secondly, in an Indian context or even in the South Asian context or wherever the poisoning is happening because of self-killing or self-harm, amount is so high that whatever you may try, probably, unless until you do a study looking into the pharmacokinetics and then trying to see whether it alters or not, there will be continue to be controversy about the use of PAM. But nevertheless, the two standard drugs which we use, one effect on the muscarinic part tries to take care, block it effect at that particular level is your anticholinergics, in particular atropine. Whereas another group of patients which we see which leads to reactivation is PAM. And we'll see what literature says, how to use, when to use, and what we have learned over last 30 to 40 years. Now you have a nicotinic sector. This is much more effective there. If you see it goes there, re-squenches in muscarinic site, you will see it is atropine. Also CNS effect, you can have a combination of nicotinic and muscarinic. Why? For me, these are more important slides because to understand the physiology The pathophysiology is the key. Why it is happening, so that you treat the patients accordingly, not by looking simply at the numbers, which we sometimes do it. So what you will see is that PAM probably is working pretty well if the drug is acting at the nicotinic receptors, whereas on muscarinic you will see commonly the atropine. Another important fact, my dear friends, is that fasciculations, muscle weakness and respiratory paralysis is a part of muscarinic receptors, whereas secretions is a part of your cholinergic part. And that's what you see it, and that is where you use sludge fast or dumbbells. And that's what we see it here. Salivation, lacrimation, urination, diaphoresis, GI upset, emesis. And the killer bee is a bronchoconstriction and bronchoria. And that's what we use when we're using antimuscarinic drugs, like long-acting in COPDs, etc. But I'm not talking about it. So that's what we see. And also what is very important is these are the effects. And when you see that in the muscarinic, there means there is a dominant stimulation of preganglionic ones, and those were ganglionic receptors. So that can lead to excess. Instead of bradycardia, you can have tachycardia. Instead of hypotension, you can have hypertension. And sometimes instead of meiosis, you can have mydriasis. Therefore, this is nothing unusual. You need to be aware about it, and to a very large extent, it depends upon the compound which have a dominant effect on the ganglions. So the mechanism toxicity is therefore simple from your perspective. Is steric inhibition of acetylcholinesterase, excess ACHH receptor, and the muscarinic and nicotinic inhibitor. Is it clear? All of you know it. The only thing is we are just reinforcing it. Then what you see, this is the acute cholinergic syndrome which we are talking about repeatedly. So you can have a peripheral, you can have a central. When you talk about peripheral, you can have muscarinic, you can have a nicotinic. Central will be sedation, central will be seizures. The effect which we don't see it, because if you are having a seizure, heart is also likely to be involved, and you will be surprised that nearly 50% of the death which takes place is not per se because of respiratory failure. It's a cardiac. How can you expect that ACH is affecting everything, it is not affecting the muscle and the conduction tissue? Isn't it? So bradycardia होता है तो आप क्या देते हैं? Atropine देते हैं. जब आप excess cholinergic कर देते हैं तो क्या होता है? Bradycardia हो जाता है. So it does get affected, and it alters the potential action potential there. And people do tend to have a higher incidence of arrhythmias, QT, interval prolongations, and they die of it. Therefore, please do remember the cardiac toxicity, which unfortunately, practically because secretions and respiratory failure has taken over. That is what I was talking about. Muscarinic peripheral effects is the diaphoresis, nicotinic peripheral fasciculation, myoclonic jerks, hyperreflexia, muscle rigidity, weakness, tremors, and paralysis. And you won't be surprised when you see it, your patients in the beds, they are finding little high tone. This is nothing else but it is telling you about nicotinic peripheral effects besides what I spoke with you. And obviously, somatic nervous system ganglia, when you have an effect at different organ systems, these are the CNS effects. Whereas in the CNS, you will see anxiety, headache, but for most important is confusion, dizziness, difficulty, concentration, and then all sort of things can come up in these cases. When you have a bradycardia, prolonged PR, chaos, QT, everything can happen. This is very important, and these are not an uncommon side effects of OP. So remember heart also when we are talking of OP. Is it clear? Now the key difference between muscarinic and nicotinic receptors is the response of muscarinic receptors. It may be, again when we are seeing it, may be excitatory or inhibitory, but what is very important is it does not affect skeletal muscles, but do influence the activity of smooth muscle, exocrine glands, and cardiac conduction system. So these effects are primarily because of cholinergic. Rest everything which you are seeing, smooth muscle function abnormalities, where you are seeing fasciculation rigidities, is because of your nicotinic. And they have a very different variability in terms of lipid solubility. And what is very important is they are lipophilic insecticides. And what you see here is relatively minor early clinical feature, recurrence of toxicity, delayed respiratory, because they all go into the lipids. And when there occurs a reverse gradient, they start coming back. And that probably you will see a persistent of symptoms and sometimes fully recovered, and later on they become unconscious. So how will you investigate? Common thing when we see in these cases, we look at blood gases and electrolyte. Blood gases to define the type of respiratory failure A, and second, obviously there you will see metabolic and oxygen parameters. Electrolytes to look there is no hypokalemia. ECG to look at QTc and any arrhythmias. XHS to see any bronchosecretions leading on to respiratory filling of the alveoli. Type 1 failure, and cholinesterase level to see how much severe it has affected, though it is not taken always as a diagnostic, but if you have a less than 50% values, then probably marked reduction is an indicative of it. Ideal should be RBC cholinesterases, but which is not there. We usually go with the pseudocholinesterases, and here the depression takes place relatively early and may stay for a month. So it's only good as far as making a diagnosis is concerned. So treatment strategy always remains the same. You have to make the patient or keep the patient alive till you are able to do other things. So you go with the airway, breathing, circulation, detoxification, right? So it is A, B, C, D, and drugs, obviously it is there. So airway, breathing, circulation, drugs, and then you have a detoxification. These all things, the D component goes simultaneously. So first look at it, stabilize, look at airway, look at breathing, look at circulation, and you oxygenate these patients before you give the first shot of atropine. Otherwise you can have a paradoxical bradycardia and patient may be difficult to revive. So first look at airway, then breathing, then circulation, oxygenate it, then go for anything else, including first shot of atropine. So as I already talked about, we need to stabilization of these functions. Now this patient was volume resuscitated, intubated and put on mechanical ventilation because she had a marked tachypnea, hypotension, and there was a problem of a secretion. So best thing is to take care of airway and take the patient on, and she was put on atropine and PAM. Atropine we have already talked about. It's a competitive antagonist of acetylcholinesterases, and it does block both central and peripheral pathways. Usually we go with the recommendation, most are fixed dose, but majority of guidelines now recommend regime by Cynthia, which was given by Cynthia Aron. And what we do is, what we have been following is 1 to 2 milligram initially, and then you keep on doubling the dose every 5 minutes in the absence of a response. And what you look at, the response will come. And once you have done it over a period of time, so you calculate over an hour how much has been given, and then you can start 20% total dose as a first infusion against the cholinergic feature. So what you do, you look at pulse rate, you look at secretions. We don't look at the dilatation of pupil. Again, I'm repeating, no dilatation of pupil. There should not be any diarrhea, there should not be any bradycardia, and secretion should dry. These are the three things we look at. And if you are looking for the dilatation of pupil, it's a bad practice because it will lead to atropine toxicity. And that's what we do. You calculate what level patient has stabilized, continue for some time, calculate how much has been given in that point of time. And then you calculate, let's say 10 milligrams or 20 milligrams have been given. So I will start 4 milligram per hour infusion. And then keep on titrating, keeping heart rate between 90 to 100, with seeing it that there is no diarrhea and there is no excessive bronchoria. These are the simple fundamentals which we follow. Clearing of respiratory secretion, cessation of bronchoconstriction will take some more time, but clearing of secretion is the key, and tachycardia and VDSs are not appropriate markers. That's what I said, 90 to 100. That is what we look at it. One thing, ensure as a resident that when your infusions are ending, sister should be ready with it. One has seen by the time they start filling it up, after it has stopped, catastrophe happening. So it's a practical tip that when you have a last 20-15 minutes, then it should do it. Doses, again, I will not go into it. That's what we follow it up. 84% reduction in the mean time to atropenization from 150 to 24 minutes. That's what we look at it. And there was a marked reduction in case fatality. So what we look at it, proportionate of patients showing toxicity from 28.4 to 12%. So what we have done here is that initially you give atropine bolus and then incremental plus infusion for OP. So that's what I'm saying. You given, let's say 2 shots, go to 4 shots, you got again, please look at it the respule, sorry, not respule, look at it the ampule which is there, which can be 0.5 or 0.6. Either of them it can come up. You can also have a 100 ml, 100 milligram. So it's important what you are using, need to know the strengths. So when person is carefully for recurrent cholinergic toxicity or onset of atropine toxicity, this is, if it is there, you may have to restart the boluses and increase the rate by 20% per hour. So if you are having symptoms, so you gradually, if I have started 4 milligram, 20% will be 0.8, roughly I increase by 1 milligram. Is it clear? So it gives you, help you in titrating. Whereas if you have a tachycardia, absent bowel sounds, hypothermia, delirium or attention, you need to stop the infusion at that point of time, and then when you restart it, reduce the dose. So you have to keep a clinical balance. So don't look at the sisters alone, please examine the patient. You will commonly see hallucinations, people just starting, agitated, looking at it, then you probably sometimes have to use haloperidol, but they are very agitated and can damage the equipment and themselves. Glycopyrronium, people tend to use it, but we use it only if person is having recurrent issues with the atropine, not otherwise. This is a replacement only if person is having a recurrent toxicity with atropine. So please revise your diagnosis. But nevertheless, if somebody has a CNS symptom, then this is not the drug. What we do in practice is that if we have to use glycopyrronium, and my youngsters when they come in the first year very fond of all rich bubbling with knowledge, but with lack of clinical experience. So I always tell them, if you are using glycopyrronium, please use, I use trade name, but it should not be trifexhexidine, that is Pacitane, which we use in Parkinsonism. It is again it's an anticholinergic, so use glycopyrronium with that. Only then it will work it out, otherwise it will not. Oximes, as I talked about the AG concept, because they attach with the hair, AHE, but bonding has not aged. That's what we look at it. Anionic sites, they look at it, and that is one is an anionic site, another is the esteric site. And obviously, this is the key when you look at organophosphates. Aging, if the water molecule adds up, and hydrolysis it causes it. So it is very important for us, acetylcholinesterase for regeneration, and that is the whole basis of PAP, that it will block it and allow it to regenerate. And age enzymes will be that if it is acting at it, and you see it, that HN is replaced. R2OP, this is a compound which is there. That's why we call them organophosphates. This is a phosphate linkage, and then this is an oxygen and here. So it is replaced by H, it is replaced by H. So once this will happen, you will say hydroxylation has taken place. I think let's move out of it. And as I said in the beginning, that dimethoxy becomes unresponsive far more earlier than your diethyl or diethoxy OP insecticides. 3.7 to 33. So it gives you a window of opportunity to use PAN. It does not give you a window of opportunity. And that also explains sometimes the variable results. One thing which has made a difference besides atropine in the management of these cases actually is mechanical ventilation. Because you take them up early and then this works. There's a huge debate among the critical care sector. The Vellore group doesn't believe in it. Ashish, also from PJ Chandigarh, doesn't believe in it. And there are a lot of other colleagues. What about me? What about I? We try to look at it when ventilator is there. We did a trial with us. We didn't find as much of a difference. But what we realized is there's a certain selective group of patients. If I find multiple fasciculation continues, or you have a myoclonus, or you have a tachycardia, or you have a marked mydriasis or hypertension for no other reasons, no atropine toxicity, that is the time we do use the bolus of PAM, otherwise not. So when the patients are coming up, we start with it, give them 30 mg per kg, and then follow the infusion of 500 milligram per hour. The only thing is, this is an empirical, we don't know how much patient has he taken up. So we don't have that. We don't go beyond 12 to 12 grams or so. Upper limit is 18 because then it also causes toxicity. But the good part is it has no cardiac adverse event. So this is the basis on which we are practicing today. Dose, again, continuous infusion we are talking about. This is the records which are there. But again, there is a huge debate. Some people come, my experience, that's fine, I respect that. But end of the day, we need to look at three things. What is the clinical evidence? What is your experience? And third is the patient one. So if your patient take on ventilators, you are relatively safe. But as I said, if you find significant nicotinic effects, it's a good practice point to use PAM in that subset of patients. Otherwise, it is not needed, not required. Is it clear? So if you have a dominant nicotinic, then you may consider, not otherwise. If the person is on ventilator, they will recover over a period of time. But obviously, you will see patients keep on jerking and having myoclonus or fasciculations. These are the various papers which have shown death in organ of poison patients they are talking about. Obviously, this is a study which is saying it as a small favor which was there, not as much against. But it's a very limited one, and if you see it, risk ratios 1.54. So usually it should be taken as effective, but later on data is there. Moderate to severe intoxication did not change the results. So the point is, in these cases, that is where there is a huge debate which is going on, and by and large, because there is not a very significant, except you will see there is a very wide confidence interval of this change study from CMC Vellore. Here, earlier one, again this is a favor placebo, favor pair. So this studies show very clearly, in this they said probably you are causing more harm by using PAM in this particular group and causing more morbidity and mortality. Rather than so sorry, I was just talking this thing. So you must remember, this is the one, the change in meta-analysis, probably which came up from Europe. When they looked at studies, they said probably you must not use, but WHO still doesn't agree with it. But this data, this meta-analysis shows that PAM is not effective is all right, but it should not be harmful. This is a selective group of studies which they are doing. We should know the limitations of meta-analysis. Certain errors can get magnified because I tend to choose with a predefined question, and then I remove half of the studies that design is not good, another half the data is not available. So you are with a small set of studies. From evidence perspective, that's what I said. In routine we don't use, but where we find a subset where there is a domination of nicotinic, there we use it. Again, you see it effectiveness for preventing intubation. Another problem in Indian context is dominantly we have a iodide, not the chloride. But nevertheless, again, the data here is showing up in the same one which they looked at it. Preventing intubation is there no difference, and placebo probably may be a shade better. Again, complications we are not finding as much. Again, it favors in terms of placebo. It is currently unclear whether there is a group of patients who will benefit. That is what we wrote it in 2015 in British Journal of Clinical Pharmacology. But we have a lot of discussions. Standard guidelines will still write as for the WHO has not changed it. Again, I am saying if you have mechanical ventilators, no issues. But when mechanical ventilator is not with you, when WHO is giving a guideline, there is no legal defense for us if it is given. So in that setting, I say, yes, you will use it. And secondly, as I said right in the beginning, that we will use primarily for dominant nicotinic effect, not otherwise. Contaminated cloth washing, when you do it, always wear vinyl gloves, not the standard ones which we are using in day-to-day practice, because it can absorb. Activated charcoal, don't roll. Benzodiazepines, if seizures are there, you want to calm down, this is a drug of choice. Soda bicarb, Plasma alkalization, people have tried, no role as of today. Alkalization in OP poisoning, people just think and that they are recommending for the design. They are still, I was talking with my friends in CMC Vellore and other places. Again, still, we have no definitive answer, so I don't go for it. She improved, extubated, day 3 became breathless. She had a poor neck holding on clinical examination. I am very fond of these patients. Raise your neck, raise your hands. What are the deep tendon reflexes? What is happening to the pupils? Is it responding? Are the extraocular muscle working well, which we call as an oculogyric crisis? So if you find clinically after 48 to 72 hours, these are the patients, what we say with the absent DTR, they have gone into intermediate syndrome. That is what we look at it. And obviously, it was first described as a type 2 by Dr. Wadia from Pune. Later on, we had a Senanaike who described it along with from Sri Lanka. But today, they labeled it as an intermediate instead type 2 because early failure, then there was a late failure, which led to peripheral neuropathy. So it fell in between. People have worked so much on it, but they are still not able to find out the answer. What my perception is, which have been Kalekarade and other people have published from Oxford and other places, is my own perception. Obviously, there is a isolation ACH receptor isomerization changes, which takes time to replace. That is one theory. Another is probably we have blocked the atropine, muscarinic receptors. What is unblocked is your nicotinic. And that is what is the story that probably is it contributing to it. So we still don't know. But nevertheless, what we know is that the major difference which is making intermortality morbidity is identification of the syndrome. Earlier we used to send this patient into the wards, suddenly collapsing and dying. Now they stay back into the ICUs and high dependency units and they're working and they do well. So can we predict it? If you find age is high, GCS is low, and there is a significant toxicity scores at present. Acetylcholinesterase levels have no value on it, but prolonged erythrocytic is yes, but we don't do it. Now, serum CK, creatinine kinase and aspartate cannot predict. So, actually nothing can do it except if you do RNS. So, the best tool is what? Clinical. You see, you look at it, whether the person is having it or not. That's why these patients, we take them on TPS in the morning, quite often by the evening, you may have to put them back on ventilator because muscles still have not fully recovered and they fail and they go back on ventilator. So be careful about it. I'm not getting into it. PAM and the incidence, some reports have reported more incidences as in this particular same group of people which have been their same studies, but we have not seen as much. She got re-intubated, atropine restarted, developed VAP, tracheostomized, improved and decannulated. So what you see is initially we saw this in the distal leg muscle leading to foot drop followed by small muscle. This is what you see on the bedside. Later it may extend proximally and even involve the truncal muscles. Gait ataxia is disproportionate. Cranial nerves and autonomic nervous are not usually involved except the oculogyric crisis which we see in the eyes and deep tendon gaps are absent. If these patients are long term on the ventilator, you need to differentiate it from critical care myoneuropathies. That is also important. Another last thing which was there is a delayed onset encephalopathy and coma. Quite often these patients recover and 6th and 7th day you see they become dopey, they become drowsy. This is a delayed onset encephalopathy, and when you see it and when your patients are off sedation, meiosis you will see they will be non-reactive to light. Everything is normal. EEG will show you a bihemic slow waves as will happen. Again the treatment is what? Atropine or pacitane, that is trifluoxetine. That's what we use in these cases. To summarize, my dear friends, it's a common poisoning. Outcomes have improved. PAM has a minimal role in certain subset of patients. Be careful of intermediate syndrome and delayed encephalopathy. It is a great antidote to the poison of enthusiasm and superstition. That's what we need to look at it. So treat it scientifically, try to find out. We still need to be more refined in terms of it, looking at HPLC and seeing what is the pharmacokinetics of the compound with the drugs we are giving, what are their pharmacokinetic and dynamics and how we can actually stop that. Thank you so much. Any questions, I will be more than happy to answer. I know it's a long day. I could see quite a few people sleeping and quite a few people talking to each other. And as usual, at least somehow, uh, it's harsh on you, all said and done. You see, usually we don't go beyond 48 hours or so, unless and until when we use it, not otherwise. And continuation of 5, 7, 8 days, it's not, if there is a recurrence, there is a relapse, then at that point of time one may think, because aging will take place in any case after that. So we look very carefully on the clinical picture. And every time I keep on telling my residents, sometimes like we have a patient recently, marked tachycardia, mild hypertension. And I said, what are the pupils? Said meiotic. I said, go and check it out. And they realized that other things are there. It was a little pediatric because confusion comes up with atropine. And we just, I said, try to give give 1 gram of PAM. We calculated it. And in front of us, another 10-15 minutes, everything disappeared. So you need to select your patients carefully. But if somebody asks in the exam, and more so if somebody is so-called purist and coming up, answer should be no sir, it should not be used. From the exam perspective, from the patient perspective, selectively, carefully pick up the patients. That's all I say. ये वैसा है जैसे हमने जीन एक्सपर्ट करा लिया, कराई जाओ, या आपने बायोफायर करा लिया, कराई जाओ. It's no use after. They have, it takes 3 to 4 weeks to come back to normal, or even some of them, even a half-life is there. Some reports even suggest up to 12 weeks. Therefore, it is maybe helpful for you in terms of diagnosis once, but after that it has no value. If you have to do it, then it is an RBC cholinesterase, which you do only either through a gas chromatography or you do with an ML HPLC with the mass chromatography, which is not a comfortable position and they were quite expensive. Anything, any other question? Yes, please. People have tried to use it, and especially the Velour group as a biochelators basically, and looking at it, but again results are variable. I have not tried, so I have no personal experience. But having said so, they do say that probably it does help. I'm not so sure about it. There are only papers basically from them and a couple of more have come up, but not being very used. But they are trying to use it as a biochelators. Any other questions? They need a good dose of 2 things: sun, tea, and some paracetamol. Thank you.
Thank you, sir, for an insightful talk.